Thank you, Nigel. We know that perioperative anaphylactic reactions may lead to substantial morbidity or mortality. And early recognition and specific prompt treatment is vital. Now, the diagnosis of perioperative anaphylaxis is a clinical one because laboratory tests are unhelpful at the time of presentation. So a sound knowledge of the clinical features encountered during anaphylaxis and a high index of suspicion by the anesthetist is essential. However, the recognition of anaphylaxis is often delayed because hypotension and bronchospasm more commonly have a non-allergic cause during the perioperative period. Now, data from NAP6 shows that demonstrate that the commonest presenting feature of grades 3 to 5 perioperative anaphylactic reactions by far was hypotension, accounting for about 46% of cases. And this was followed by bronchospasm or high airway pressure in 18%, tachycardia in 9.8%, a flushing or non-urticaria rash in 6.6%, cyanosis or oxygen desaturation at 4.7%. A reduced or absent capnograph trace was recorded at 2.3%, and it was the 7th commonest. 3 patients presented with cardiac arrest. Urticaria was not a common presenting or clinical feature during anaphylaxis, even in patients with pre-existing urticaria. In severe reactions, urticaria may not be seen until resolution of hypotension. In approximately 1 in 20 cases, an awake patient reporting feeling unwell was a harbinger of anaphylaxis. Now, presentation was very similar, regardless of whether the anaphylactic mechanism was allergic or non-allergic. Taking into consideration all clinical features occurring at any time during the anaphylactic event, hypotension was also the commonest, occurring in all patients. Rash, which was seldom a presenting feature, subsequently developed in about 56% of patients, and this was followed by bronchospasm, tachycardia, cyanosis, and a decreased or absent capnograph trace. Interestingly, airway problems were rarely seen. 15 patients presented with isolated cardiovascular features. In asthmatic patients, bronchospasm, either as a presenting feature or clinical feature during anaphylaxis, was more common than in patients without a history of asthma. Bronchospasm was also more common in morbidly obese patients. In contrast to asthma, there was no difference in presenting or clinical features in patients with or without a history of coronary artery disease. However, patients with coronary artery disease are more likely to experience fatal events. In patients taking beta blockers or ACE inhibitors, hypotension was the main presenting feature and was common during anaphylaxis. And these patients were more likely to have higher grade reactions. Now, this slide shows the presenting features of the 3 common neuromuscular blocking agent culprits. Atracurium was commonly associated with hypotension, whereas the commonest presenting feature with suxamotonium was bronchospasm or high airway pressure. Rocuronium was associated with both bronchospasm and hypotension in approximately equal measure. When all clinical features were taken, occurring during anaphylaxis were considered, hypotension was also the most common for all 3 neuromuscular blocking agents. It is notable that amongst patients with anaphylaxis to neuromuscular blocking agents, women were overrepresented. There were 46 women and 19 men. The cardiovascular features were also the predominant presenting features in antibiotic-induced anaphylaxis, especially with teicoplanin anaphylaxis, where hypotension was dominant and bronchospasm was uncommon. Hypotension was the main presenting feature when with anaphylaxis due to chlorhexidine and patent blue dye, and bronchospasm wasn't seen. Amongst patients with chlorhexidine anaphylaxis, there were 16 men and 2 women, whereas all patients presenting with patent blue anaphylaxis were women undergoing breast or gynecological surgery. In the majority of cases, the presenting features appeared rapidly within 10 minutes of presentation. In only 5 cases was this delayed beyond 60 minutes. When the culprit agent was a neuromuscular blocking agent, presentation was rapid. In all but 1 case, presentation occurred within 30 minutes. And in all cases related to mivacurium, rocuronium, or succinylmaltonium, presentation occurred within 10 minutes. An isolated case of atracurium anaphylaxis presenting at greater than 120 minutes was probably a data entry error. When anaphylaxis to antibiotics were considered, presentation was similarly rapid, 97% occurring within 15 minutes, and all reactions occurring within 30 minutes. Now, some slower reactions were seen in anaphylaxis with chlorhexidine and patent blue dye, often delayed beyond 10 minutes and even beyond 120 minutes. It's interesting to note that the speed of response by the anesthetist may vary according to the presenting features. Response time was always under 10 minutes when the presenting features were cardiac arrest, bradycardia, reduced or absent capnograph trace, and laryngeal edema. Longer delays occurred when the presenting features were hypotension, bronchospasm, cyanosis, and non-specific flushing. A reduced or absent capnograph trace was recorded in 30% of cases. There was no clear correlation with the severity of the reaction. And unrecordably low oxygen saturation or occurring at any time during the anaphylactic event was reported in 31 cases. And these reactions were more likely to be grade 4 or 5 with a more rapid onset, and anesthetists were prompt in suspecting and treating anaphylaxis. Now, several publications have suggested that a higher proportion of perioperative anaphylactic reactions occur in women. However, data from NAP6 show that the higher number of women with perioperative anaphylaxis was actually proportional to the higher number of women undergoing surgery and anesthesia in general. Nevertheless, subgroup analysis revealed twice as many women as men when the culprit agent was a neuromuscular blocking agent, and a preponderance of men when the culprit agent was chlorhexidine. Now, underdiagnosis of anaphylaxis is common, especially when cutaneous involvement is absent. NAP6 data indicate that although the presenting features may vary, hypotension was universal during the perioperative event. Unexplained perioperative hypotension should be considered as anaphylaxis should therefore be considered as a differential diagnosis of unexplained perioperative hypotension. Now, perioperative anaphylaxis can present as isolated organ system involvement, and this was observed in a small minority of NAP6 patients. And we should exercise a high index of suspicion in recognizing perioperative anaphylaxis, because not all patients present with a full-blown picture with involvement of the cardiovascular, respiratory, and mucocutaneous systems. We noted some important patterns in presentation depending on the culprit agents and patient comorbidities. Hypotension was the commonest presenting feature in atracurium anaphylaxis, and bronchospasm or high airway pressure with succinylmaltonium anaphylaxis. Hypotension was also the commonest presenting feature in chlorhexidine patent blue, and antibiotic anaphylaxis. As expected, hypotension was the main presenting feature in patients taking beta blockers or ACE inhibitors. In the vast majority of cases, and for most culprit agents, presentation was rapid, occurring within 10 minutes of exposure. Exceptions to this were with CHLORHEXIDINE, patent blue dye, where presentations may be more likely to be delayed. It's not surprising that for most cases, presentation was rapid because most drugs are delivered intravenously during the perioperative period. With respect to CHLORHEXIDINE and patent blue dye, the delay is very likely to be due to the time delay in absorption of the allergens. Some clinical features are clearly of immediate concern to the anaesthetist, and as you notice, cardiac arrest, or are commonly associated with anaphylaxis. And these appear to prompt anesthetists to suspect anaphylaxis and to start treatment swiftly. Other clinical features, in particular hypotension, occur relatively commonly during general anesthesia, or have causes far more common than other causes more common than anaphylaxis. And these confounding issues may lead to a delay in recognition and treatment of anaphylaxis. Although bronchospasm or high airway pressure is commonly associated with exacerbation of asthma or airway stimulation, it may also be a presenting feature of anaphylaxis. And so we should exercise caution in attributing perioperative bronchospasm solely to the exacerbation of bronchial asthma. A recent study suggested that an untitrated carbon dioxide value of less than 2.6 kilopascal is a useful independent marker of severe anaphylaxis. Now, if this is correct, then this observation could be potentially very useful because capnography is routinely, continuously monitored during general anesthesia. And any sudden reduction in end-tidal CO2 values could prompt us to suspect and manage anaphylaxis. However, data from NAP6 has not confirmed this finding. Although we did not ask reporters to record the end-tidal CO2 values, we did ask whether an absent or reduced capnograph trace was present. And this was reported in just 30% of all patients. So whether this casts doubt on the previous finding or indicates a failure to recognize and record this change is uncertain. We found that patients who had an unrecordably low oxygen saturation at some point during the anaphylactic event had more severe reactions with prominent respiratory components or cardiac arrest or profound hypotension. And these reactions were promptly recognized and treated by anesthetists. An unrecordably low oxygen saturation may be an additional useful sign in recognizing severe reactions. So in summary, perioperative anaphylaxis is a clinical diagnosis. And although presenting features may be varied and may have multiple other causes than anaphylaxis, key early recognition is still key to successful treatment. In particular, anaphylaxis should be considered in unexpected perioperative hypotension. And in asthmatic patients, bronchospasm or high airway pressure is a common presenting feature of anaphylaxis, and this should therefore be considered in the differential diagnosis. We should bear in mind that perioperative anaphylaxis can present as isolated organ system involvement, and cutaneous signs are uncommon presenting features, especially in the more severe cases. Most reactions present rapidly within 10 minutes of exposure, and because these events are rare and occur unexpectedly, education and training in the recognition and treatment of anaphylaxis is essential. Thank you very much.
Thanks very much indeed, Cale, and thank you to all the speakers for keeping so well to time. We have 15 minutes for questions and answers before lunch. Bill and Susanna and Harry, if you'd like to come up to the podium. I'll invite questions, and as before, we do have a roving mic over there.